Top Bed Talk.
Hello, my name is Dr. P.J. Devereaux. I'm a cardiologist and perioperative care physician at McMaster University, and it's my pleasure to be part of this conference. I want to thank Mike Grocott for inviting me to be part of this. Today I'm very excited to share with you the results of the accelerated surgery versus standard care in hip fracture, the hip attack trial results, and I'll be doing this on behalf of the hip attack investigators. As part of my university policy, we're supposed to put up our disclosures at the start of all of our talks. I'm a member of a research group which has a policy of not accepting direct payments from industry for our own personal financial gain. We will, however, accept funding from industry to conduct research endeavors and for costs to participate in meetings. Based on study questions I've originated in grants I've received from the following companies that are listed here. What is most relevant for you to know is that we did receive a little bit of funding from Octapharm and also Stryker related to hip attack trial, but the hip attack trial was overwhelmingly funded by peer-reviewed grants. 10 years ago, I was consulted to manage a 73-year-old female with a hip fracture who had an elevated troponin when she had presented to the emergency room. The referring physician had indicated to me that the patient's heart issue had to be treated before her hip surgery could occur. I was on that week for the coronary care unit. I saw the patient, admitted them to the CCU, and I consulted one of my interventional colleagues because she had ST changes, ST depression. On the Saturday, this was a Friday night, they called me. On the Saturday, they were too busy in the lab, took her to the lab on Sunday, saw a mid-LAD lesion, intervened upon, patient came back to me on dual antiplatelet therapy. Patient ended up having a major bleed and died before she ever made it to the OR for a hip fracture. So despite the best of intentions, the medical management this patient received resulted overall in her death. This raised the question to us whether or not, in fact, patients may have better outcomes if they go directly to accelerated surgery as opposed to delaying surgery. Patients with hip fractures undergoing surgery have higher risk-adjusted mortality than patients undergoing elective total hip replacement surgery. We demonstrated this in a study that was published in JAMA, led by Yannick Lamanok in our group, and published in JAMA. This suggests the possibility that hip fractures themselves may initiate pathways that increase a patient's likelihood of dying, and perhaps if we shorten the exposure to those pathways, perhaps we can improve outcomes. We also undertook a systematic review and meta-analysis of observational studies that demonstrated that accelerated surgery in patients with a hip fracture was associated with lower mortality and major complications compared to delayed surgery. In the observational studies, it did not matter how accelerated versus delayed was defined. It could have been greater than or equal to 72 hours, 48 hours, or 24 hours from the time of diagnosis. In all of these studies, there was a demonstrated benefit towards accelerated surgery. Separate research shows that it is insufficient operating room time and medical optimization that tend to be the main barriers to accelerated surgery, and we thought we could potentially overcome these barriers. The objectives of the hip attack trial were to determine whether accelerated surgery for hip fracture was superior to standard care in reducing death or major complications. This was a randomized controlled trial. The inclusion criteria was that we included patients aged 45 years or greater who were diagnosed with a low energy mechanism hip fracture that required surgery. We excluded patients who were on therapeutic dose anticoagulation without an available reversal agent, patients who had a periprosthetic open or bilateral fractures, and patients who required emergency surgery for another indication. Patients were randomized either to accelerated surgery, and here our goal was for patients to have surgery within 6 hours of the diagnosis of a hip fracture, or patients were randomized to standard care. In the standard care group, we did not delay surgery. Surgery occurred as per the normal timelines at that center. We had two co-primary endpoints at 90 days of follow-up. The first was all-cause mortality. The second was major perioperative complications, which was a composite of mortality and non-fatal myocardial infarction, venous thromboembolism, pneumonia, sepsis, stroke, and life-threatening or major bleeding. We randomized 2,970 patients in 69 centers in 17 countries, and greater than 99% of patients completed the 90-day follow-up. The mean age of participants was 79 years of age, and over 2/3 of the patients were female. 61% of patients had a history of hypertension. A third of patients needed assistance with activities of daily living. Just over 20% had a history of diabetes, and 18% had resided in a nursing home, and 18% had a history of dementia. Intertrochanteric fracture was the most common type of fracture at just over 50%, and femoral neck fracture made up for 44% of the fractures. The type of surgery performed was most commonly open reduction and internal fixation for 2/3 of patients, and arthroplasty for 1/3 of patients, of which hemiarthroplasty was the most common. If you look at the time from hip fracture diagnosis to the start of surgery, we achieved our goal in the accelerated care group. That is, the median time was 6 hours. In contrast, in the standard care group, the median time from hip fracture diagnosis to surgery was 24 hours. This is a median absolute difference of 18 hours, a result that was highly statistically significant. If you look at our primary outcomes at 90 days of mortality and composite of major complications, there was no difference in the results between patients randomized to the accelerated care group or the standard care group. If we look at the components, or we look at some of the secondary outcomes, which are mainly components of the composite endpoint, again in this slide you see that there was no difference in the results between patients randomized to accelerated surgery versus standard care. However, when we look at outcomes for infection and neurocognitive outcomes, there were differences that favored patients randomized to accelerated surgery. If we look at infection without sepsis, this occurred in 170 patients randomized to accelerated surgery versus 207 patients randomized to standard care. The hazard ratio is 0.80 and the result is statistically significant. And if we look at stroke, there was 5 patients randomized to accelerated care who had a stroke. In contrast, there was 14 randomized to standard care that had a stroke. The hazard ratio is 0.35, a result that is statistically significant. However, we encourage cautious interpretation of this outcome because there were few strokes. In contrast, there was a lot more delirium. 132 patients randomized to accelerated care had delirium, whereas 175 patients randomized to standard care had delirium. The hazard ratio was 0.72. That favored a lower risk of delirium in patients randomized to accelerated surgery, a result that was highly statistically significant. When we looked at the types of infection, it was urinary tract infections that were lower in patients randomized to accelerated care. 120 patients randomized to accelerated care had a urinary tract infection, whereas 150 patients randomized to standard care had a urinary tract infection. The hazard ratio was 0.78, a result that was statistically significant. If we look at tertiary orthopedic complications, there was no increase in patients randomized to accelerated surgery for either hip reoperation, prosthetic hip dislocation, implant failure, periprosthetic fracture, or surgical site infection. And looking at our timelines, the time from randomization to mobilization to standing and full weight bearing, all of these outcomes were improved with accelerated surgery, and the overall absolute difference was favoring accelerated surgery by 21 to 26 hours for mobilization, standing, or full weight bearing. And looking at the time from randomization to hospital discharge, this occurred a median of 10 days in the accelerated care group versus a mean of 11 days in the standard care group, an absolute difference of 1 day, a result that was highly statistically significant. In looking at outcomes around moderate to severe pain, these demonstrated an advantage to patients randomized to accelerated surgery from day 4 through to day 7. The proportion of patients who were in the accelerated care group had a lower probability of having moderate to severe pain if they were in the accelerated care group. These results were statistically significant. We had 2 a priori subgroup analyses based upon the timing from fracture to hospital arrival and also whether or not patients had an acute severe medical condition. This slide here is showing you the subgroup analysis result for mortality. And as you can see, the interaction p-value on the right-hand side of this slide is not statistically significant for either of these outcomes, supporting that, in fact, the result based upon the timing of the hip fracture to hospital arrival or whether or not patients had acute severe medical conditions was consistent for patients in the accelerated versus standard care group. Important to note that there was very few patients who had acute severe medical conditions, and these were things like ST elevation, myocardial infarction, a need for intubation and ventilation. If we look at the same subgroup analyses for our second co-primary endpoint of 90-day major complications, the interaction p-value for time from fracture to hospital arrival was statistically significant. However, the hazard ratios went in the opposite direction to our a priori hypothesis. That is, we hypothesized that the faster patients arrived at the hospital, the more benefit from accelerated surgery, whereas we saw the opposite. Of note, these results did not demonstrate within any of the subgroups statistically significant results, and we suspect that this is likely a chance phenomena. Again, for for acute severe medical conditions, there was no interaction by treatment group. We undertook further subgroup analyses based upon the type of surgery, whether or not it was open reduction internal fixation versus arthroplasty, and demonstrated consistent results across these subgroups. We also undertook a subgroup based upon an expanded list of acute medical conditions, and once again demonstrated consistent results, and importantly did not demonstrate any evidence of harm with accelerated surgery when patients had any acute medical condition at presentation. The final subgroup analysis I will show you is based upon the patient for which was the impetus for this trial that I had managed with the elevated troponin when she presented with her hip fracture. And here we see, when we look at 90-day mortality, the interaction p-value is highly statistically significant. And what we see is that when patients are in the accelerated care group and they did not have an elevated troponin at baseline, the risk of death at 90 days was 8%. In patients randomized to standard care, the risk of death was 8%. The hazard ratio was 0.98, and it was not different between the two groups. In contrast, in patients who arrived at the emergency room with their hip fracture and had an elevated troponin, the patients who were randomized to accelerated surgery, 10% had died within 90 days, whereas in contrast, in the standard care group, 24% of these patients had died within 90 days. The hazard ratio was 0.38, and the result was highly statistically significant. Looking at the subgroup analysis, again, based upon troponin elevation at baseline, now looking at the outcome of 90-day major complications, the interaction p-value was just above 0.05. It was 0.06. However, the results, again, were consistent with mortality. That is, if patients did not have an elevated troponin at baseline, and they were randomized to accelerated surgery, the likelihood of a major complication was 20%, and in the standard care group, it was 22%. The hazard ratio 0.91, a result that is not significantly different. In contrast, if they were randomized to accelerated surgery and had a baseline elevated troponin, their likelihood of a major complication was 21%, whereas in the standard care group, the probability of a major complication was 34%, hazard ratio 0.56, and a result that is highly statistically significant. So in conclusion, among patients with hip fracture, accelerated surgery did not significantly lower the risk of mortality or major complications. There was, however, no evidence of harm even in the subgroup with acute severe medical conditions or any medical conditions. Accelerated surgery did demonstrate a lower risk of delirium, urinary tract infection, and moderate to severe pain scores on days 4 through to day 7. We believe that these are likely credible effects. The reason we think delirium went down is that likely it went down because patients were mobilized faster, they had less moderate to severe pain, and they also had less urinary tract infections. The urinary tract infection signal is likely also real because a lot of patients have urinary catheters placed when they arrive in the emerge with their hip fracture, and this is only removed until sometime after surgery. And because in the accelerated care group, surgery happens faster, the catheters will come out sooner. Accelerated surgery also demonstrated faster mobilization, standing, and full weight bearing, and also a shorter length of hospital stay. Accelerated surgery demonstrated a lower mortality advantage in patients with an elevated troponin before randomization. In implications, accelerated surgery for a hip fracture is safe and feasible. With troponin elevation before randomization, there was a mortality advantage with accelerated surgery. The logistics and resources required for accelerated surgery need to be balanced with the demonstrated benefits and patients' desires for accelerated surgery. We published the results of the hip attack trial earlier this year in The Lancet. I want to acknowledge all of the members of the writing committee for the hip attack trial and all the investigators who made this trial possible and all the patients who participated. Thank you very much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.